Have you ever wondered if low energy, low drive, and low motivation was something else? Have you ever had thoughts about starting TRT, but just really didn't know where to start? In this video, we're breaking down what testosterone replacement therapy is, how it actually works, and what you need to know to start treatment. Whether you're just curious or seriously considering TRT, this is your one-stop guide to testosterone replacement therapy. Testosterone replacement therapy is exactly what it sounds like. It's about replacing the body's natural testosterone levels. It's not about supercharging the body's testosterone levels, but it's more about finding a balance in a system that's out of sync. TRT is not for everyone. It's reserved for a condition called hypogonadism in men, where the body doesn't produce enough of its own testosterone and comes with clinically significant side effects. Let's start with the first one, primary hypogonadism. This is a condition where the body's own testicles are not producing enough testosterone. Examples include Klinefelter's disease, testicular injury, or chemotherapy-induced damage. Number two, secondary hypogonadism. This is affecting the pituitary gland and the hypothalamus. So specific conditions that affect either one of those. So that could be pituitary tumors, that could be head trauma, that could have happened from an injury, or that could be chronic opioid use. And thirdly, functional age-related hypogonadism. This is probably the most common one. This is where testosterone naturally decreases over the course of your lifespan. So factors include age, obesity, and chronic illnesses. Think of the body as slowing down, not a full shutdown. And less common is post-psychotherapy or PCT. This is where men who have used anabolic steroids and it has suppressed the hypothalamus pituitary gonadal axis. And this is where you need to restart the natural production of testosterone. So now that we've covered when TRT is used, the next logical question would be, what are some formulations? Injectables are going to be by far the most popular formulation. They can be injected intramuscularly or subcutaneously, can be dosed once weekly or bi-weekly. It offers precise control over dosing and testosterone levels. You also get to bypass the liver or the first pass effect. It's the best balance of efficiency, convenience, and cost. The next most popular formulation is going to be topicals. So that's your gels and creams and pumps, any of those. It's usually applied topically onto the skin, usually from the elbow up to the shoulder on both arms to increase surface area. It must be applied daily. You have to have fine control over the dose. And when you apply it, you want to make sure it's dry, so you're not transferring it to someone else. It doesn't have the best absorption capabilities. It's actually fairly inconsistent. It's best suited for men who have an aversion to needles, but overall it's just less reliable. Less common options are going to be pellets, which are implants underneath the skin that release the medication over the course of months. There's a nasal gel, which has to be applied multiple times a day. It's very inconvenient. Then there's also oral testosterone, which is toxic to the liver, like the older formulation, like methyl testosterone, not used in practice. I've personally never seen it being used. It's not very bioavailable, and like I mentioned, toxic to the liver. There is new formulations like the Getenzo and Tolando, which do bypass the first pass effect. They get absorbed into the lymphatic system, but even then they have very low bioavailability. In most clinical settings, injectables are going to be the gold standard. They offer the best mix of predictability, customizability, and cost effectiveness. Now that you understand what testosterone is and when it's used, let's dive deep into some of the science of how it actually works. In order to understand how testosterone works in the body, we first need to go over some basic physiology. This will be the hypothalamus pituitary gonadal axis. This is the body's internal testosterone control system. How does the hypothalamus pituitary gonadal axis actually work? Well, the hypothalamus releases GnRH, which is gonadotropin releasing hormone. This will stimulate the anterior pituitary gland to release two hormones, follicle stimulating hormone and luteinizing hormone, which will have their various effects on the testes. Luteinizing hormone will stimulate the Leydig cells to release testosterone. And follicle-stimulating hormone will stimulate the Sertoli cells to support spermatogenesis, or the production of sperm. In order to control this system, the body has set up various negative feedback loops. One of them is testosterone and estradiol. So testosterone gets converted to estradiol via aromatase, which is an enzyme. Testosterone itself and E2 or estradiol will have negative feedback on the hypothalamus and telling it to produce less GnRH, which in turn will produce less LH and FSH, which in turn will have less production of testosterone from the testes. Now the opposite is also true. When testosterone or estradiol are low, GnRH levels will ramp up, producing more testosterone. This will increase LH and FSH, which eventually downstream will stimulate the testes to produce more testosterone. So the key point here is that the entire system is well controlled with this negative feedback loop. Even the slightest changes in testosterone or estrogen levels can shift the entire balance. Now that we've covered where testosterone comes from, let's zoom in on the bloodstream where testosterone exists. Free versus bound testosterone. So when testosterone enters the circulation, most of it actually binds to two different major proteins. It's going to be sex hormone binding globulin, or SHBG, or albumin. That's going to be the bound form of testosterone. Then there's also going to be free testosterone, or free floating testosterone, which is unbound. Only a tiny fraction of testosterone is actually unbound. Most of it is going to be bound to SHBG, and which will render it inactive, and some of it will be loosely bound to albumin. And that loosely bound can have some effect, but the majority effect is coming from the about 2% that is unbound. In the clinical setting, free testosterone is actually what matters. This can be calculated from total testosterone, SHBG levels, albumin, and it can be plugged into a formula known as the Vermeulen's formula. This brings us to an important concept that many people actually overlook. SHBG can completely change how testosterone behaves in the body. I'll give you two examples. Normal testosterone, normal total testosterone with either high SHBG or low SHBG. Let's look at the low SHBG example. So if you have low SHBG, or sex hormone binding globulin, that means that more testosterone is in the free bound form. What does that mean? More testosterone in the free bound form means that it's becoming metabolized much faster. If you have higher rates of metabolism of free testosterone, you will have less available testosterone for its androgenic and anabolic effects. So even though total testosterone may look normal, free testosterone will actually dip much faster. So a treatment strategy in that example would be to use more frequent and smaller doses. In the opposite example would be high SHBG, so a higher fraction of testosterone is bound up to SHBG and is inactive. In that scenario, you would actually have symptoms of low testosterone, even though on your labs your total testosterone may look normal. In that scenario, a treatment strategy would be to use a higher total dose. Secondly, as I mentioned, testosterone is produced by your body in a pulsatile manner, not in a continuous manner. So throughout the day, and especially at night when you're in deep sleep, your body, the hypothalamus, will release GnRH in pulses, and that GnRH will spike your LH from your anterior pituitary gland, and in turn, that spike in your LH will cause a release of your testosterone. So you'll get a burst of testosterone from the testes. So these bursts throughout the day and especially at night create sort of a wave-like pattern where you have troughs and you have peaks, not a constant flow. So why does this rhythmicity matter? This is the natural fluctuations of your testosterone that your body produces. It helps to maintain mood, libido, energy, and even sleep quality. So the key point here is that your body is optimized to work with a rhythmic testosterone release, not a continuous release. And this will become more important when we jump to the next section of exogenous testosterone. Testosterone doesn't act alone. It transforms into two important metabolites, DHT and estradiol. And these major metabolites shape your mood, your physique, and even your hairline. So testosterone itself has direct effects on androgenic receptors. So it has androgenic effects and it has anabolic effects. So androgenic effects would be things like body and facial hair growth, deepening of the voice, prostate development. Anabolic effects would be things like muscle growth, bone strength, erythropoiesis even, so producing more red blood cells. So these effects are dose and age dependent. So testosterone is actually converted to one of its major metabolites, which is estradiol or E2, via an enzyme called aromatase, which is highly expressed in fat tissue. So estradiol is essential for mood stability, libido, joint comfort, bone density, and cardiovascular health. So the key point to remember with estradiol is that it's more important for libido than testosterone, contrary to belief. So men who feel worse after taking an aromatase inhibitor often have very low estrogen or E2 levels, not high enough estrogen levels. The other major metabolite is going to be DHT, or dihydrotestosterone. Testosterone is converted from T to DHT via an enzyme called 5-alpha reductase. This enzyme is especially prominent in the skin, the prostate, and scalp. So the DHT effects are actually quite a bit more potent than testosterone itself, about 3 to 5 times more potent. It can also drive the external genital development, hair patterning, so the face, the chest, the pubic hair as well, and scalp hair loss for individuals who are genetically predisposed to losing hair, and also prostate growth. And this contributes to BPH, or benign prostate hyperplasia. So DHT is actually critical for masculinization, but in high amounts, it can actually lead to oily skin, acne, and hair thinning. And now that you understand how endogenous testosterone affects the body, I think we're ready to talk about the exogenous testosterone entering the system and how it disrupts, bypasses, or even replaces parts of it. Let's walk through what exogenous testosterone does to the body and how it affects some of the natural negative feedback loops that the body has in place to regulate testosterone. So most testosterone in TRT is actually delivered in injectable form, as it's the most popular form. This could be either intramuscular or subcutaneous, and it's typically some sort of ester, which is going to be just an oxygen, or sorry, a carbon bound to an oxygen, double bond, so a carbonyl group, and then you have an R group on one side, and then you have an OR group on another side. So basically you have testosterone with a fatty acid chain, and the length of the fatty acid chain can differ. Most popular is going to be cypionate and enanthate. So that just describes the length of that fatty acid chain that is bound to your testosterone. So what happens is when you inject testosterone into the muscle or subcutaneous tissue, it actually forms an oil depot. And over time, from that depot, testosterone slowly gets released into the bloodstream. And this happens over the course of days. Once in the open circulation, exogenous testosterone acts identically to endogenous testosterone. So it binds to SHBG and albumin. And then you also have your free-floating testosterone as well. It converts to estradiol, E2, and DHT, just like how endogenous testosterone does. And it activates the androgenic receptors as well. But here's where it diverges from endogenous testosterone, because it bypasses the entire HPG axis. When exogenous testosterone is in the bloodstream, the brain detects the elevated levels. And instead of suppressing testosterone production, it actually shuts down the entire HPG axis. It can lead to a few effects: testicular atrophy, cessation of sperm production, and often infertility. The key point here is that exogenous testosterone replaces your endogenous production. It doesn't restore it. So now that testosterone is coming from a vial into your bloodstream instead of your testes, what happens to its metabolites? Hormones like estradiol and DHT. This brings us to the first point that I will discuss: aromatase inhibitors. Testosterone, whether naturally or exogenously, can be converted to estradiol or E2 by the enzyme aromatase, especially in fat tissue. In some men, this conversion happens at a much higher rate, And this can lead to things like bloating, mood swings, and even gynecomastia, which is breast tissue development. To reduce some of these symptoms, what clinicians will do is they will prescribe an aromatase inhibitor, something like letrozole or anastrozole. But here's the catch: you have to fine-tune the aromatase inhibitor, because if you take too much, too high of a dose, or too high of a frequency, you can actually crash your estradiol or E2, and this can have significant side effects. Things like joint pain, depression, decreased libido, cognitive issue, also known as brain fog. So the key point here is, if you feel worse after starting an aromatase inhibitor on TRT therapy, most likely you're at too high of a dose and you are crashing your E2 in the gutter. So if exogenous testosterone completely shuts down your HBG axis, is there a way to preserve fertility? The answer is yes. So how does this work? SERMs block estrogen receptors in the hypothalamus, tricking the brain into thinking that estradiol is actually low. This leads to increased release of GnRH, which will spike your LH and FSH and will tell your testes to produce natural endogenous testosterone, and it will support spermatogenesis, even in the presence of high estradiol. So this can be used for fertility preservation, post-cycle therapy, or restarting your natural production. At this point, you can see how TRT is much more than just injecting exogenous testosterone. It's about understanding how testosterone behaves in the body, how it alters natural regulations, and how we can support or suppress related hormone pathways. But this is just the beginning. In part 2 of this video, we're diving deep into real-world considerations on TRT, things like injection routes, dosing considerations, and risk factors like clotting and increased hematocrit. If you're thinking about starting TRT, or if you're already on TRT and want to optimize your results, part 2 is where things get practical. Be sure to subscribe and turn on notifications so you don't miss when the next video is posted. I'll see you there.